Good afternoon, and thanks for joining us for today's Healthline 3 conversation. I'm Courtney Butts, and today's topic is all about interventional cardiology in the year 2025. Joining me today to talk about this is an interventional cardiologist, Dr. Ryan with Willis Knighton, Dr. Ryan Master, with Willis Knighton. Thanks for joining us.
Thanks for having me.
Absolutely. Interventional cardiologist,
Yes.
So a little bit more specialized than regular cardiologists.
Correct. I specialize in interventional cardiology. I practiced general cardiology, but did additional training in interventional cardiology. Interventional cardiology was the first recognized subspecialty of cardiology. It's a field that's mostly a procedure-based field, and the cardiac catheterization lab, where we do invasive procedures, evaluating people's heart arteries. If you have a blockage, that we can stent with a balloon and a stent. That was really the founding of it. And now it's kind of evolved into different aspects of different interventional procedures that we can do for the heart and as well as the vascular system.
Gotcha. Yeah, so it sounds like you cover really a lot of different spectrums when it comes to someone struggling with heart disease, or maybe you mentioned in our midday newscast even like peripheral arterial disease. So it can kind of cover a lot of different bases there.
Yeah, some interventional cardiologists have different interests, and so some of us focus on different things. Most all interventional cardiologists will treat heart artery disease, coronary disease, but some specialize, like myself. I have an interest in peripheral artery disease, so dealing with blockages in people's lower extremities and upper extremities. Some of my colleagues do carotid artery disease as well, where they do carotid stents. And so there's some overlap with other interventional groups like interventional radiology, vascular surgery, and then structural heart disease as well. We kind of touched on that a little bit as a growing area as well.
Okay, and so you have a special interest in PAD, right? But you can still treat heart artery disease, but you have just a specific interest in that field.
Yeah, I have lots of interest.
Yeah.
PAD is one of those. So a couple of us in our group have an interest in PAD and do peripheral interventions, where some other interventional cardiologists do not do that. I love coronary disease. I love doing complex coronary interventions. You don't get into cardiology without an interest in that area, especially with interventions. So we do things like someone coming in the middle of the night with an emergency heart attack where the artery is completely blocked and they're having severe chest pain. It's very gratifying that we're able to open that artery up and treat the blockage, and then the patients feel better almost instantaneously. And so that's a gratifying area, but we keep busy in different other areas such as peripheral artery disease. And there is some overlap in the causes of these disease and the medical management of them, and then the interventions, they kind of have some overlap.
Gotcha. Yeah. So with interventional cardiology, you mentioned that there's been a lot of advancements in this field, specifically maybe just even in the last decade. Can you tell us a little bit more about those?
Yeah, I have kind of a unique perspective in cardiology and interventional cardiology. My father was a cardiologist in the area for over 40 years.
Cool.
And so he moved here in the 70s. There was no interventions in cardiology at that time. They were doing diagnostic heart caths. They learned how to do heart caths. Originally, cardiologists are not surgeons, but we do some surgical type procedures like pacemakers. They would do brachial artery cut down. So they would cut down to the artery to get access, put a needle in the artery, and then run a wire up to the heart. In the 80s, that changed more to going through the femoral artery in the groin. And now there's been a revolution where using what we call radial artery technique. And now over 90% of the heart caths I do, we go through the artery in the wrist. Much less risk of bleeding, less downtime. Patients are able to leave the hospital faster with that access. So it's funny how in 40 years, 30 years, we went back from the arm to the groin and back to using the arm again. The field has touched on it a little bit. In the 80s, was when we first started doing interventions for acute heart attacks. Stents did not exist in the 80s. They were just doing balloons. And the problem with balloons is that you could tear an artery and you may not be able to treat that artery. The patient may have to urgently go to surgery, or that the vessel would recoil, come back, and the blockage would return quickly. And that would happen upwards of 30% of patients. In the 1990s, they developed stents. And so stents are little tiny metal cylinders that a balloon expands, the balloon deflates, comes out of the body, and the stent stays in the body and adds a little bit of reinforcement to keep that open.
Right.
And that has improved to drug-coated stents, and then now we're doing this type of stuff throughout the legs, and then now developed technology like the TAVR, where it's a stent design with a valve inside it.
Very
and
cool.
So pretty amazing stuff, and it continues to grow year to year. There's always new things and new tools.
Absolutely. Yeah, we mentioned TAVR, and I want to get to that. But first, we do have our first caller. Joe, thanks for joining us. And what's your question for Dr. Master?
Sure, thank you. And thank you, Dr. Masters. I had a incident last week. Had to go into the cardiac unit in Texarkana, St. Michael, and they ran a battery of tests over 4 days. I have a median acute ligament syndrome. The septic artery is being pinched by a ligament. They're talking about doing a major surgery. Just thought I'd get your opinion of, a second opinion here. Thank you.
Yeah, so that's a little different spectrum from what I typically deal with. That is involving the arteries in the abdomen. Typically, for a procedure, I don't know exactly what the issue that you're having, but sometimes there's compression of that vessel depending on somebody's anatomy and maybe how they're born with. It may be that they've developed a blockage in that area. If it's an anatomic issue, generally a vascular surgeon or a general surgeon can sometimes intervene with open abdominal surgery or laparoscopic surgery to correct that.
Mm-hmm.
Is that similar to what they've been telling you?
Yes, it is. Yeah, very much so.
Yeah, like a CT scan probably was the initial diagnosis that they used, and you're seeing a surgeon?
Yes, I am. He did a heart cath on me, 4 days of test, MRI at least 4 times with contrast, various things.
Yeah, they probably did people will call it a heart cath, but when we do peripheral interventions, we go through the groin. It's an angiogram, and we use similar equipment to how in the cath lab, so they can take some better pictures to help visualize and understand what's going on.
Yes, they actually inserted it through my wrist, my right wrist, and I actually got to watch the screen while they were going through my artery. It was rather interesting.
Yeah, we do these procedures with generally moderate sedation, so we can give more sedation if somebody needs more sedation, make them more comfortable, anxious. Some people fall asleep and are arousable, but if somebody's comfortable and awake and they want to look and see what's going on, and we can talk to them, during the case. It's a little bit less risk for the patient rather than, heavier sedation.
Okay. Well, great. I appreciate your time.
You're very welcome.
Yeah, thanks, Joe, for the call and for the question. And if you're just joining us, that number is right there on your screen. It's 318-219-4569 if you had a question for Dr. Master. Again, we are talking about interventional cardiology as specific to, so maybe direct your question specific to that, and he can give you his expertise on your question. Again, 318-219-4569. And previously we were kind of talking about, well, first, we do have another caller. Pamela, thanks for joining us. And what is your question?
My question is, I have a regurgitating left valve. I had a heart attack, like one in October, and I was curious if that I need another opinion. And I started having problems with my heart again about a week ago, and I just been released from the hospital a week ago Wednesday, and I don't know if I was born with that or what, and I wanted to know where I need to go from here.
Well, I'm sorry to hear about your issues, Pamela. Obviously, you mentioned that you had a heart attack in October, and so the
Yes.
appropriate things is that you're on the appropriate medications. Did they do a stent at
No,
that
sir.
time?
No, sir. That was my first time ever been addressed with that. I've never had any chest pains or problems before. I was a smoker. No longer I am, but I have COPD too, so I don't know if they contribute all that, but I was just wondering what suggestions you had as for go from here. I am on a cardiac diet now. I told them about that when I was at the Soda Regional here. And I have seen some improvement. I haven't had any pain since I've been on. Thank God for that.
Oh, good. Yeah,
Do you have any suggestions for me as for seeing a cardiac doctor?
yeah, it sounds like if you've not seen a cardiologist, then that sounds reasonable if they're
I have
telling you.
never seen one.
Okay.
Yes,
Well, yeah, the workup, sometimes things like heart attack get discussed, and really the only way to definitively know is to do a heart catheterization. There are blood tests called cardiac enzymes, troponin, and those get checked frequently in ERs in the hospital. And the hope was that if somebody was having chest pain and has a elevation in their troponin, that is a diagnostic of a what we call non-ST elevation heart attack. Unfortunately, there are other causes that can cause those things to be up. It's flu season right now, so we get called frequently for people who have bad cases of the flu, and they can get inflammation of their heart. And that's not a heart attack, but they get this troponin, and somebody may say, oh, well, you had a small heart attack, when really they didn't have a problem with their artery at all. You mentioned on having a leaky heart valve. There are four valves in the heart. You said it was on the left side. We have the mitral valve and the aortic valve. People can have congenital issues with these valves that they've had their whole life. A little bit of mild or trace leakage of the mitral valve is physiologically normal. Depends on the extent of it. If somebody's had a major heart attack, they can have damage to the heart muscle, and that affects the heart's ability to function properly. Especially the mitral valve is a little bit more complex than the aortic valve. It has these tethers that tie it to the walls, and if that wall isn't moving well, those tethers may not be moving as well, and you can get secondary leakage from a major heart attack. And there are procedures that can be done surgically and as well percutaneously if you're not a good candidate for surgery. Medications is typically how we start treating that, and if patients are refractory to medical therapy, then they need something done.
My shooter, thank you for that.
You're very welcome.
I have one more question, sir. Also, when you follow your diet correctly, like I said, it's only been a week since I've been home. They said I had like a flu, and I also had high blood pressure. So does all that tie in with that too, causing the problem, sir?
Yeah, unless having your chart and diagnosis to see exactly what was going on. But yes, in terms of your health going forward, obviously recovering from the flu, resting, following up with your primary care physician about making sure you're not having any long-term problems from there. But blood pressure control, diabetes control, getting off cigarettes, getting the cholesterol under control, all of those things are preventive for the development and worsening of vascular disease.
Yes.
And the diet is a nice way of doing that in terms of what we consume affects our blood pressure and our cholesterol.
Mm-hmm.
Yes, sir.
Well, thanks,
Well,
Pamela,
I
for
will
your
get
question.
with my provider. Ma'am,
I was just said thanks for calling and asking us your questions for our doctor today.
I sure do thank you all for the insight, and I will get in touch with my provider and go from there.
Great. Awesome. Yes, well, if you're just joining us, 318-219-4569 is the number to call if you have a question. And I'll continue my questions now. We've talked a lot about maybe even just the structural heart components as well, if you want to talk a little bit about how that plays into interventional cardiology.
Yeah, we touched on earlier about the evolution of stents, and that was the kind of the boom of interventional cardiology, and then it kind of settled down. And in the last 15 years, TAVR was the biggest new structural intervention. They started doing TAVR in the United States. It got FDA approval in 2011. I'm actually giving a talk a little bit on aortic stenosis and TAVR this weekend. They're having a small interventional cardiology meeting, or general cardiology meeting rather, in town called New Cardiovascular Horizons.
Cool.
But TAVR, when it first came out, was only for non-operative or high-risk patients. The majority of patients with aortic valve stenosis tend to be older in age. It's typically a disease of the elderly, 70s to 80s, 90s. And some of these patients may have had prior heart surgery, lung disease, or other comorbid conditions, such as just being frail, that they were not great candidates for surgery. And if the surgeon or the patient didn't want to do a surgical valve replacement, there was really no treatment option for them, and it was a terminal illness. And so TAVR, originally we were doing it mostly in people in their 80s or more complex medical history, higher risk. And the recovery from a TAVR compared to surgery was the biggest advantage. Both valves seem to do very well. They've made improvements in the last decade in the technology with the TAVR valve. When I first started doing TAVR, we were doing size 24 sheaths. A typical heart cath sheath is a size 6. So this was tremendously larger.
Wow.
And the engineers do such an amazing job. They've gradually shrunk that down to using, it's still a big size sheath that we put in the femoral artery, but a size 14, a size 16. TAVR is done with a cardiac surgeon and an interventional cardiologist. When we first started doing TAVR, about 30% of cases needed surgical access because of the sheath size. But by shrinking it, now over 95% of the time we do it with no surgical access, just percutaneous access. So
That's awesome.
That's been a big improvement for patients. And TAVR right now, 2016 got approved for intermediate risk, and in 2019, low risk patients. So now more aortic stenosis is treated with TAVR as compared to a surgical valve replacement. Still, surgical valve replacement's an important tool. Some people's anatomy, if they have comorbid conditions, so they need a bypass and an aortic valve, or they need another valve to be treated.
So now that with these advancements, you mentioned that it was a terminal illness, basically. What is the outcomes? What do they look like now?
Yeah, so aortic valve replacement has always done very well for patients who get a surgical valve, but if you're not able to replace the valve, the disease will continue to progress. If you replace the valve, you've got a normal functioning heart valve, your life expectancy should be similar based on your other conditions.
Okay. Well, we do have another caller, and thanks for joining us. Gene, what's your question?
Okay. I've got a very rare, unique situation. Okay. I was diagnosed with fourth stage cancer when I was 39 years old, colon cancer. Went through quite a bit of radiation, chemo, lost part of my rectum, and anyway, the outcome has been nothing but vascular issues since then. My question is, I have CAP, PAD. I have stents all down my legs, my neck. My heart has a valve. They had to replace the heart valve on the right side. None of the stents will ever hold the legs. So they've had to go in and replace some arteries, veins rather. So is this just something that's just going to continue for the rest of my life?
Yeah, unfortunately, once you've developed vascular disease, it's a lifetime disease. Patients have to manage that with medications, lifestyle. It sounds like possibly, from your surgeries, from the radiation can affect the arteries as well. I have a question for you. Were you ever a smoker?
Yes, I was.
Okay. And you've quit smoking currently?
Yes.
Okay. Yeah, that's one of the biggest issues we have for peripheral vascular disease. People who continue to smoke have higher rates of re-narrowing. When I try and do an intervention, we try and get it right the first time. But sometimes, patients have more severe disease. It sounds like you've had multiple interventions, and it's always what I find, if you get a nice result and that result holds, those patients tend to have better long-term results. Once you have re-narrowing, the process is a little bit more challenging. There are things that we can do to treat blockages. In the peripheral arteries, we use what we call drug-coated balloons. So balloon angioplasty, especially for arteries in the thigh. I prefer that instead of stents, because once you start having issues with stents, you've started that cycle of re-narrowing. But if you have an occluded stent, sometimes doing a balloon inside of it instead of stacking it with another stent can be helpful. Making sure you clear out those stents. We sometimes have devices called like a laser atherectomy device, where we have a wire down the artery and the laser helps to debulk some of that debris. So there are some interventions that you can do that can help, and then again, keeping the cholesterol down, walking, all of those things. Hopefully you and your doctors can find a better long-term solution for you to help prevent these recurrent episodes.
Yeah, because it's like about every 2 years I'm going back in for some, surgeries. And it just drives me crazy that the stents in my neck held well. I've never had a problem with those. Haven't had any problems with the heart valve. So I'm just curious, is there something else that besides my medications and diet to help with the reoccurring?
Yeah, it has to do with the interventions that you've had previously. Certain vessels have higher rates of re-narrowing, as we talked about. And sometimes there are certain procedures that can be done that may get a better result. But as in life, there are kind of no guarantees on that. So again, ask these questions for your doctors that have been treating you, and see what they say, and get them to explain what they think is going on. Exactly.
Yeah, because one of the issues is that I'm getting to the point that they will not be able to do anything because of all this scarring from so many surgeries.
Yeah.
One of my issues is they're talking about, they probably cannot do it again and would have to remove my leg.
Unfortunately, with peripheral artery disease, sometimes it's too far gone. It depends. There can be multi-level disease. So we talk about the iliac arteries, the femoral arteries, and the arteries below the knee. There are two reasons why we do peripheral artery interventions. So one is somebody has symptoms with walking. They tend to get cramping in their calves. So a blockage upstream affects something downstream. And that can be life limiting for some people. Even going to the grocery store affects them. And there's some medications that we can try. And if that's effective, we leave it alone. But if it's not, doing a balloon, a stent, some revascularization procedure, or a surgery can alleviate that. The other reason is that somebody has a non-healing wound on their foot. And so I work very closely with podiatrists and wound care teams, and they'll usually direct me, okay, a wound is healing, we won't do an intervention. All right, is there something that you can do? And we'll try and get as much accomplished to help with the blood flow. And the wound care team and the podiatrists work closely with the patient. So it's a real team approach.
Yeah.
And so it's gratifying that we can do what we call limb salvage. So somebody has a toe amputated instead of a foot or a leg.
Absolutely. Well, Jean, thanks for calling in, but we do have another caller. April, thanks for joining us. And what is your question for Dr. Master?
My father's side of the family all died of heart disease, and my mother's side of the family didn't. And I wondered, does heart disease go mainly through the father's side of the family? Is it transmitted to the female side of the family? I was curious about that.
Yeah.
Did I make sense?
Yes, it does. And the answer is I have not seen any genetic relationship like that. The genetics of heart disease is a bit complicated, still not fully understood. And it can be multifactorial. So somebody in their family can have a condition called familial hyperlipidemia, where they have severe high cholesterol levels. We've also seen other cholesterol levels such as lipoprotein a, which is a hereditary condition, not either maternal or paternal and inherited. And so you can get that genetic condition, and that can lead to premature heart disease. But there are some other genetic factors that more research is being done to figure out why someone gets heart disease at an earlier stage in life. And some of it can be also lifestyle too. So some families' lifestyle may be a healthier lifestyle, what they ate, smoking, other things like that.
Very interesting. Yeah, very interesting topic there. Genetics, unfortunately, we can't change them, but we can change our lifestyle, which is also important. What would you, real quick, we have just 2 minutes left, couple of lifestyle things that someone should change right now?
Yeah, so exercise, eating right, that's the number 1 and 2 thing for most people. Obviously, if you smoke, getting off of cigarettes, peripheral disease, coronary disease, we really don't see peripheral disease in non-smokers unless severe diabetes. So getting out, any exercise is good. Obviously, more aerobic exercise is better for the heart, not even just for heart artery disease, but for the stiffness of the heart, keeping the heart in shape.
Yeah, very good things that we could do right now, and especially in honor of American Heart Month, things to really consider and keep in mind to protect your heart, so, and your vascular system and all that good stuff. So we have just about a minute left, but if someone is interested in getting in contact with you or maybe becoming a patient, are you accepting new patients right now, and how can they reach out?
Yes, I get patients in 2 ways. So I do general cardiology, so referrals from primary internal medicine doctors, as well. I work at Willis Knighton, Piermont Cardiology, so they can call our office, ask for an appointment, and then other cardiologists refer me patients for special conditions.
Okay, yeah, because you do specialize in the interventional side as well, but you also see general cardiology patients too.
Correct.
Okay, what is your phone number so people can get in touch with you?
The phone number for our office is 318-212-3858.
All right, and website, I guess, just Willis Knighton Piermont Cardiology, and look up Dr. Master. Pretty
That's
easy
correct.
to remember. Okay, well, great conversation. I didn't even get to half of my questions. We had a lot of great callers, and hopefully we're able to help some people today. Thanks for joining us, Dr. Master. And this will be on our website, ktbs.com/podcast, if you wanted to rewatch it or if you missed it. Thanks for joining us.